as we move toward other emerging options for relapsed and refractory diffuse large B-cell lymphoma, we have a number of new potential agents that are out there. One that is undergoing regulatory review right now is the anti-CD19 antibody tafasitamab. And it's been studied primarily in combination with other agents, including lenalidomide. So I know, Cami, you have led the discussion or led some of the trials around tafasitamab. Can you tell us a little bit about what it is first for the audience that may be unfamiliar, and some of the initial studies that have been done primarily in relapsed and refractory large cell lymphoma with this agent in combination, particularly lenalidomide?
Yeah, so tafasitamab is actually a CD19 monoclonal antibody. The FC portion has been enhanced to increase ADCC and ADCP. There was a single-arm study that looked at the monoclonal antibody tafasitamab alone in relapsed refractory non-Hodgkin's lymphoma, and they saw some responses in diffuse large B-cell lymphoma, but notably there was a handful of patients who achieved a complete remission, and the median duration of response in those patients was over 20 months, signaling that there might be some activity in this agent with large cell lymphoma. So the combination tafasitamab and lenalidomide was evaluated in a phase 2 study that combined the two drugs for 12 months. The antibodies given once a week for the first 3 months, and then every other week for months 4 through 12. And lenalidomide was given at a dose of 25 milligrams. After the year of therapy, patients were allowed to continue on tafasitamab maintenance. The further rationale of this trial is that the lenalidomide activates NK cells, and that brings more cells for tafasitamab to act on. So the phase 2 trial of the combination showed pretty high response rates. It showed a 60% overall response, with a little over 40% of those patients achieving a complete remission. The patient population in the study they were allowed to go on trial with relapsed refractory disease with a median prior therapy of 1 to 3, and the population was a median prior therapy of 2. So these weren't extensively or very heavily pretreated patients, but it was really targeted at those patients who relapse after their initial therapy or maybe receive a first salvage and then are not candidates for autologous stem cell transplant. The therapy was pretty well tolerated, with the toxicities mainly being hematologic, fatigue, and diarrhea. Really, when you looked at the toxicities after the first year of treatment, the majority of them resolved, really suggesting that the toxicities that were seen with the combination were primarily what you see with lenalidomide alone. There were very few infusion-related reactions, and about 3/4 of the patients were able to stay on a len dose of 20 milligrams or higher.
So, Matt, I want to ask you your take on this agent, and I think we just talked about CAR T-cell data and we'll come back to whatever comparisons we can draw. But how does this compare in your mind to either lenalidomide alone or an anti-CD20 alone? Are these patients characteristic of this population? I wonder, are they the same people we're seeing with CAR T-cells? I know the Remind study tried to make some comparisons, obviously different cohorts, but kind of how you put this into the context of interpreting this phase 2 data with regard to this agent or this combination in light of the patient population that we may want to, in the future, apply this combination to.
So, Dr. Maddox, correct me if I'm wrong here, but I was just waiting for the publication, and I think it came out recently in Lancet Hematology, because some of the methodology of the study too is that the patients couldn't have double hit or triple hit biology, and my understanding is that you couldn't have been primary refractory to your first line of therapy. So if you were refractory to R-CHOP or dosage-adjusted EPOCH, you couldn't be in the study also. So there's some differences there, because we've seen, in CAR T-cell therapy, those patients double hits, CAR T cell appears to be agnostic. It doesn't care that you're a double hit. You can still respond and have durability. Same thing is that if you're primary refractory, you're still going to CAR T cell, likely double refractory with a lot of disease, and those people who have gone, chemotherapy jumping from one to the next. So I think there is certainly a population difference between, Zuma 1, Juliet, and likely Transcend compared to the L-MIND. Now, don't get me wrong, the data that Tafa and lenalidomide is putting out is impressive. 40% response rates. I think at EHA, they just looked at the duration of remission in those people at 2 years. And so there's definitely, some synergy here, because lenalidomide, alone is not putting up those numbers in relapse refractory large cell lymphoma. Your PFSs you're looking at, I think, is around 3 to 4 months, and that's even in combination with rituximab, where you would say, oh, that lenalidomide resensitizes rituximab. I guess that's the one thing that I would have been looking at in the R-MIND or the REMIND study is an R-squared arm compared to the lenalidomide alone arm. I mean, they went through a lot of patients looking for lenalidomide monotherapy patients that met the criteria for the L-MIND study to compare 1-to-1. I think another thing that would have been interesting is you kind of hinted at that, Dr. Maddox, is a GCB ABC with lenalidomide, but we've seen data from other groups, at least retrospectively, that there may be some GCB, patients that do respond. And you got to think with the follicular lymphoma data with R-squared, that GCB, there's got to be some people out there that would respond in that setting also. But the data's impressive. I do have concerns about what is CD19 manipulation or perturbation going to do to the CAR T cell. There is some preclinical data with TAFA and looking at cell lines, and that it does engage the same CD19 antigen that you would expect that the CAR T cell would go after. But at least in cell lines, it didn't appear to affect CAR T cell. Now that needs to be bore out in reality. Because I think we're going to see if this drug does get a label or is in use, a lot of it getting used, because it is an IV therapy given weekly, for a lot of doses up front, and an oral therapy that, people are very comfortable with using in lymphoma and multiple myeloma. So I think it will get a lot of use. And I think we're going to have to be very, very on top of our game as CAR T cell lymphoma doctors to really capture the data of those patients who are previously Tafa-Len exposed that don't respond or get a PR and go to CAR T cell therapy to see what the true durability is. And I really think that that's only going to come out of with real world experience data rather than a commercially funded experience.
So I'm going to ask both of you, Cami and Matt, again in a second, kind of if you had both of those available, both of those approaches available, how would you think about it? But first I want to ask Nathan. Nathan, you've been very involved with lenalidomide studies in a number of different contexts. The REMIND study, as I understand it, took kind of a historical group of patients treated with lenalidomide alone, and then the prospective group treated with the combination of tafasitamab and lenalidomide, and try to combine them. And I think we have to be careful about retrospective versus prospective comparisons, et cetera. But kind of what's your take on the logic and at least the biology of why lenalidomide might work with this drug, and your take on this combination in this particular setting?
Yeah, so Matt said it very well. The thought is with lenalidomide across, at least in the lymphoma space, is that there is augmentation of antibody response that could possibly due to changing antigen recognition, increasing NK cell activity and T cells. And so that would make a lot of sense that you combine a drug like that with a monoclonal antibody, then it's going to make that monoclonal antibody better. What I think that has a lot of people scratching their head is, why is 19 so much better than 20 when you add lenalidomide? And so this 19 probably has some other effects within the microenvironment. We know that it's involved in signaling within the B cell. It's involved in MYC signaling. So there may be something else that's different about combining 19 with Rev again, is it somehow affecting the microenvironment? I don't think we truly understand why, at least with the data we have, we don't have anything head to head, but if you look at the phase 2 studies with R squared, which we did here at Anderson, the response rate and the PFS is dramatically shorter than we see with 19 plus Rev. I think that and if you look at the duration of response in the CR patients, it's phenomenal. That they just published in this paper. It's like 80-90% in patients that achieve a CR. So I know that's not the answer to your question. I'm not sure why the mechanism looks so much different when you hit 19 versus 20 combined with Rev. I think that, Rev has multiple mechanisms. I think those are all probably related to how they're affecting non-malignant cells within the microenvironment. And that clearly is important with